Hi everyone, this is Lucia Billeci. I am a researcher at the Institute of Clinical Physiology of the National Research Council of Italy located in Pisa. And my study is entitled An Alternative Approach to Home-Based Rehabilitation of Children with Spinal Muscular Atrophy. This study has been performed by our group at the FSC CNR in collaboration with colleagues from the Stella Maris Foundation and Neuropsychiatric Center located here in Pisa. The main purpose of these studies is to evaluate the feasibility and efficacy of a novel approach for the home treatment of children with spinal muscular atrophy. The approach is based on the use of the Nintendo Wii console, in particular of the sport game of the Nintendo Wii, to have a rehabilitation, in particular of the upper limb, which is interesting and engaging for the children. In addition, we want to introduce a non-invasive evaluation of physical performance by using wearable sensor for surface electromyography assessment in order to have an objective evaluation of the effect of the treatment over time. For those of you who are not familiar with spinal muscular atrophy, I just want to say a few words about the disease. It's an autosomal recessive disorder which is caused by a mutation or even absence of a survival motor neuron 1 gene. Fortunately, the disease is quite rare. Its incidence is about 1 in every 6 or 10,000 infants. The clinical presentation of the disorder includes progressive muscle atrophy and weakness, while intellect and sensation remain intact. There are 4 main types of SMA. The difference is in the onset of a disease and also in the severity. And according to the different type of SMA, the incidence is different. In our case, we are going to address the type 2 SMA, which has an onset at about 6 to 18 months years old. The incidence of this type of SMA is about 20-30% of SMA case. And children are typically unable to stand or walk without support. And they have problems, particularly in breathing and also cardiac problems, which are often the primary case of death or complications for these children. The traditional and most used approach for treating these children is using pharmacological treatment, which are aimed to address mainly the breath and the cardiac ability because they can really impact their lifestyle. But according to the most recent standard of care recommendation for patients with SMA of 2018, there is an increased importance of the use of physical therapy for these children because physical therapy can really influence the trajectory of the progression of the disease. So this type of treatment is more proactive since it involves the subject in a primary manner. This is a graph from the quite recent review of 2018, which showed the different type of physical therapy promoted for these children. And there it goes from aerobic, balance, strengthening, stretching, and standing. While the use of aerobic treatment is more debated because it can influence breathing, cardiac ability, the other type of approach are well used and adapted for these children. Our approach is mainly based on strengthening muscular force, as I will show you later. According to another recent review of 2021, there are several barriers and facilitators which can impact the effect of physical therapy for these children. Looking at the facilitators, the most important two are the parental and caregiver support. Of course, for children, the role of parents is necessary, and also the attendance and participation in the physical therapy. This is important because the treatment needs to be engaging for children, otherwise they will not follow the treatment in a proper manner and the efficacy is reduced. Looking at the barriers, the limited availability of resources, including equipment and facilities, the limited access to transportation to go to the place where the treatment is provided, and the limited amount of financial resources can limit the effect of a physical therapy. So in our approach, we try to overcome the barriers while looking at the facilitators, providing a treatment that is based at home, so it does not require transportation and access to facility, is quite cost effective, and it's engaging for children. Home treatment for children with SMA is not really still used in the literature. There are very few studies addressing this topic. Here I reported 2 of them. In the first one, 9 children with SMA, aged about 10 years old, completed a resistance training exercise program at home for 3 days a week, and each session is about 45-60 minutes. The training is supervised, so it needs that the physical therapist goes at home and supervise the exercise. The authors demonstrated that this kind of treatment is feasible and safe for the children. They used some scales to assess the effect of the treatment, and they found no differences in muscular strength, but an improvement in motor function. In the second study, 38 children completed the vibration system home training. It consists of the use of a vibration platform, which provide a vibration to the muscles, and so induce an involuntary contraction of the muscles. The authors find a significant improvement in mobility after 12 months of training in a subgroup of children. So these 2 studies show that the home treatment is feasible for this subject and produce an effect, an improvement in motor function. There are some limitations. In the first one, a physical therapist is required for supervision, so it's not completely unsupervised. And in the second study, the platform, the device used is quite expensive and not easy to be provided to subjects. So in our study, we want to try to overcome some barriers, providing a treatment that is cost-effective, engaging, and that use a low-cost device. So it is a pilot study, so we enrolled 2 children, 2 females, aged 8 and 9 years respectively, with a diagnosis of type 2 SMA, which were enrolled at the Stella Maris Foundation in Pisa. And we provided the training using Nintendo Wii game console. Surface electromyography is acquired at multiple time points for the evaluation of the effect of the training on the muscular strength. So the first procedure regards the same game selection. The game were analyzed, and there is a verification of training possibility for SMA2 children. Then the children were categorized according to their level of mobility, and so their capability to play to the different games. And the games were finally evaluated and classified according to the level of mobility requested. So these are the 3 levels of performance of the subjects. The level 1 is the less severe level. So the subjects have good trunk, shoulder, and elbow mobility, and also mobility of the forearm. While in the level 2, the trunk and shoulder mobility is reduced. And in the level 3, that is the more severe, the subject has no trunk or shoulder mobility. The subjects that we are addressing are level 1 subjects, so they are the less severe level. Games were categorized in 3 categories based on the movement patterns required to play the game. The first category regards repetitive activity games, which are characterized by repetitive alternating movements of the upper limb, and the force required is mainly isotonic. The second category refers to games with reduced movement, so they require the activity of muscles that control posture and proximal upper limbs, and the force required is mainly isometric. The third category are skill games, which are characterized by complex and coordinated movement, and the force required is fast and the gesture is impulsive. This first table shows the repetitive activity games analyzed, and in particular we decided to select the tennis game, also including the preference of the subject in this choice, because it's a really personalized approach, so we want to be sure that the subjects are interested in the game and can be engaged in the game. And this is a game that requires holding the Wii remote with one hand and use it if it were a racket. It's an unimanual game, and the level request is 1 or 2, so it's it's fit with the subject enrolled. The second category regards games with reduced movement. So these are games that can be performed also by subject of level 3, the most severe level. And since our subjects are level 1, we decided to not select one of these games in this pilot study. And the first category regards the skill games, which are the most complex game, so they are suited for subject of level 1. And also in this case, we select one of these games, that is the golf game, which require to use the remote control like a golf club, and this is also an unimanual game. The home intervention consists in playing these 2 games at home. Each game needs to be played at least 15 minutes for an overall time of 30 minutes a day for 7 days a week for 6 weeks. We performed a first evaluation at T0, where the children were clinical assessed using some functional scale, and the surface electromyography signals were recorded during a task that I will show you later. Then we perform another assessment after 3 weeks of training and after 6 weeks of training. There is also a final assessment after 12 weeks, so 6 weeks than the ending of the training. So we wanted to see if the effect of the training persists over time, also when the training is finished. The surface electromyography acquisition is performed using wearables developed by the BTS bioengineering group. They are very lightweight and small probes, so they are really suited also for children. And we selected 2 muscles for the recording, the brachialis and the brachioradialis of the dominant arm, because these are the muscles that are more solicited during the treatment that we provided. Just a few words about the surface electromyography. It allows the detection of electrical signals arriving at the skin surface, so they not measure force per se, but the electrical signals sent by the motor nerves to muscle fibers to create force. So it's possible to use different probes to have surface electromyography signals of different muscles. And so we can record information about the fatigue mechanism. Fatigue is usually defined as the loss of voluntary force-producing capacity and can have both a central and peripheral origin. In our case, we are addressing peripheral fatigue, which is due to the accumulation of lactate and extracellular potassium. So the acquisition of surface electromyography signal provides useful information about several underlying mechanisms of fatigue. This is a typical signals that we obtain using surface electromyography probes. So we have we can identify several contractions of the muscles, and plotting the power spectrum of the signal, we can say that during fatigue there is a lowering of the amplitude of the spectrum and also a reduced peak frequency. So amplitude and frequency can be used for information to assess fatigue of the muscles. The surface electromyography task that we implemented to measure muscular fatigue is an easy and enjoying task for the subject. The subjects are requested to squeeze for 5 seconds, then releasing for 3 seconds a ball, following a sequence delivered through an application display on a PC screen. The application displays a cartoon, alternatively keeping a bone on its mouth for squeezing or normally acting for releasing. We extracted several features from the surface electromyography signals acquired. These features are both in the amplitude and frequency domain, and are related to the fatigue mechanism. In particular, we extracted the mean rectified value, the root mean square, the energy, the mean, and the median frequency of the signals. Then we applied a principal component analysis approach to identify the most significant features for analyzed fatigue in the subjects, and the two features that were selected were the energy and the median frequency. In the graph on the left, we can see one of the signals required. We can identify different muscle contractions. So the signal is segmented in the different contractions. The spectrum is plotted, and then we measure the features for each segment identified. The clinical outcome of the approach has been identified using some functional scale. In particular, the Hammersmith Functional Motor Scale has been administered to the subjects. It's a 20-item scale addressing different motor ability like sitting, rolling, translations or crawling, and standing or stepping. The maximum total score is 40. And since our subject has a level 1 SMA, so they are not so severe subjects, both patients score 40 at every evaluation. We introduced also another scale, which is more adapted in identifying the functional ability of the upper limb. So it's a 9-item scale assessing different motor ability like moving a pencil, tear a piece of paper, and so on. And the maximal total score is 18. And we noticed that the subjects had a slight increase from T1 to T4 in this scale, specifically for patient 1 from 15 to 17, from patient 2 from 15 to 16. Here we plotted the median frequency for the two muscles that were recorded using surface electromyography and the two subjects. We can see that for the first subject, there is a quite stable pattern of a median frequency, meaning that the subject is not experienced fatigue during this protocol, while for the second subject, there is a quite decrease to 2 of the median frequency. So subject is experienced fatigue at a certain point, but then the median frequency increase again. So the fatigue is reduced at the end of the treatment. Looking at the energy, also in this case, we had a bit of a reduction of the energy at a certain point of the treatment for both subjects, but then the energy rise again and since maintained also at the T3, which is the last recording point after the end of the treatment. So it seems that this kind of treatment not produce fatigue for the subject, and in a certain level the fatigue is also reduced for the muscles at the end of the treatment. So of course, this is a pilot study, but yet we can draw some conclusion. For sure, the approach is feasible, and while highly accepted by the subjects, were very enthusiastic about the protocol and follow the treatment at home. And they were happy to have the possibility of choose the game and playing the game at home. According to the clinical evaluation, there is a little improvement in the upper limb motor function. And regarding muscle fatigue, we can say that the training is at a certain point determines a little increase of muscle fatigue, but then following the training, the muscular strength and the fatigue decreases. So overall, the training seems to have a positive effect in the patients. Regarding future trends, of course, we need to enroll a larger cohort and also have a control group of subjects which are not undergoing to the treatment. And it would be important also to integrate the assessment with other physiological parameters. In particular, we are thinking about electrocardiogram and respiratory function, since this subject has impairment in breathing and cardiac function. And we also would like to provide the non-monitoring, so using a wearable sensor also to have an assessment of the performance at home. This is all. Thank you for your attention.